Lower extrusion attachments often fail. It's a beveled attachment and the main force application is tilting the tooth towards the tongue. Teeth will always move unless they touch something. So release that, create microspaces and the tooth will go. In today's video, I'm going to react to a clip I shared recently. It got a lot of interesting questions and reactions. The aligner push there. What's going to happen? That tooth is just going to move inside. And that's why I feel that attachments, extrusion attachments, the normal extrusion attachments on the bottom doesn't work.
Would you agree that at the end of that video, you look a bit upset?
Normal extrusion attachments on the bottom. Frustration.
Why frustration?
Because I've had a number of cases recently that I've used 25 to 30 aligners to do extrusion and the predictability was very low.
When you say extrusion attachments on the lower teeth don't work, what exactly is failing biomechanically?
Your best force application is on a 90-degree in the direction that you want to apply forces. Otherwise, you can make use of the other forces, but in a 90-degree fashion, you don't have any vectors that break down. So if you have, if you have an attachment lying like that, but you want to push the tooth there, 90 degrees give you a force without any side effects to any other area. So that direction on that attachment, but vertical is there, is going to push the tooth over. So if you want to go up, and that is extrusion, you have to push 90 degree up. But to get an attachment on a tooth with a big enough surface there, you have to go very far off from the buccal surface. So it's going to be a huge, big attachment. And the problem is with the bottom teeth, so use all these nice things. They are, if this is a tongue, they're all lying in like that. So to get a vertical attachment lying like that, to be able to push literally up and not have a force tilting it to the inside is difficult. I have tried rectangular attachments with a vertical component, and the bigger you make, the longer the length you give, the bigger surface there is, the bigger your force. But a flat vertical, no, sorry, that's a horizontal one. I have to correct myself. A horizontal attachment there. It's got a very thin area which the aligner can hook on and push it up. So it's unforgiving because if it doesn't hook around that edge properly, which can happen if your bonding isn't good. So the bonding, the attachment on the screen looks very sharp. It's a square. But once you've bonded it and you've done you removed the flash and everything, and the patient starts putting it in and out, taking the aligner out, putting it in, taking it out. That little corner wears away and you get less and less grip. And eventually that aligner doesn't grip underneath that attachment. So a beveled attachment where you get the bevel, sorry, I'm going to use this again, where the bevel is in that direction. You apply the force up, so you you don't have a 90-degree force. Most of the forces in that direction, as I said, is going to push it in, but you get some forces that goes up. But at least the bevel makes it the attachment that the aligner doesn't lose grip on the attachment. So that's good you've asked me this question, then I have to add to that. From a purely biomechanical viewpoint, if you look at a rectangular attachment, it would give you a more surface, more grip on it. But practically in the clinic, you lose the attachment wears off, and depends on the clinician how well they do fit that attachment, work off the flash, and how beautifully, and the quality of the composite they've used. If the composite isn't highly filled, then it wears off, and you don't get that sharp edge that you need to pull the tooth up.
You said that the tooth is just going to move inside.
The aligner push there. What's going to happen? That tooth is just going to move inside.
Can you explain what that looks like clinically?
One would really describe it as a collapsed tooth where the buccal root torque is overexpressed. The root goes out to the buccal side and the crown is tilting towards the inside. And the danger of that is once a patient starts chewing, if you finish your occlusion and the angle of the tooth in that at that angulation, and the patient applies any bite forces on the tooth, it's not going through the center of the root, it's not going through the long axis of the root. So you've collapsed it already to the inside, and bite forces is just going to make the bite collapse even more.
How does the crown shape or the inclination of the arc contribute to that failure?
The crown shape, I'm going to use my hands, is rounded. Where your upper crown is more flat, you've got a curve, but the bottom ones are more rotated in. If this is the tongue, and then the upper teeth bites there, you can't have the attachments there. The upper tooth is going to bite it off, so you have to move it quite low, and then you've got a curvature there. There's a limited area that you can have the attachments, and the lower you go to the bottom and your angle is not right, you're going to do this.
How did you first realize the standard attachments weren't working the way that you expected?
Well, you can see that after one case. Then after the second case, you start asking yourself questions. Am I going to do that? And after the third case, you start making other plans. And after the fourth case, you've got your other plans in place and it works so much better, then you don't want to go back to attachments.
If attachments aren't reliable, why do you think aligner companies keep using them?
No, they are reliable depending on what you use them for. For extrusion, they don't work. But for instance, for rotations, you do need them. You can't get away with them. The trick for me with attachments is just the clinical part. It's one thing for the company to have beautiful attachments and the biomechanics is worked out and it's force. They've got beautiful names for it. But once the clinician has put it onto the teeth and they work away the flash, they tip, they touch the attachment, the tiny attachments with a drill, or it wears off over time. You lose so much of your force on that attachment.
You said in your LinkedIn post, my solution to this problem is the following. Create microspaces to free the teeth, anchor the aligner on the canine and molar, allow the premolars to erupt passively guided by the aligner, following the same principles as dull in restorative dentistry. Once the premolars have reached the occlusal plane, anchor them and let the molars erupt next. In my experience, you said, this passive eruption happens much faster than when staging extrusion with attachments. So my next question is, what is your thought process behind creating microspaces?
Well, it's a very, very well-known orthodontic principle. When we did fixed braces, when you do your cases, you don't have a scan, you can't look, you can't get into between the teeth. The patient is biting there. So you're just looking from the outside and you hope that there are contact. But once you remove the braces, we always have the saying, the teeth will settle. And sometimes the patient is in a hurry, they're fed up for the braces, they want it off. And you can see the teeth are in the right positions, they just have to over-erupt and make contact. Teeth always move till they touch. Then you remove the braces and you see the patient after a while, and it hasn't happened. Now you've removed the braces and now you're in trouble. You have to get those teeth to fit. And some cases settle in and others don't. And I've all asked myself the question, why? And started working with aligners and getting to understand the biomechanics of aligners, because you work with a very light force. You can't have any collisions. A collision is just where two teeth touch and it causes friction and they don't want to move. So because of the very light nature of aligners, collisions is a no-go. Where with braces you can handle the collision, you just increase your force level. And that's the same when you've removed the braces and you want the teeth to settle. There's no additional force to make them move into that contact point over erupting. So if there's collisions, if there's tight contacts, and you leave a slightly open bite, it's not going to settle. And that's just the reason why I create microspaces. I don't want to waste the patient's time. I don't want to waste aligners. And I know I need microspaces for them to move. And so far, so good. It's worked every time.
The second part of the solution that you mentioned, you said anchoring the aligner on the canine and molar. So my question to you is, how does that change control?
First, before I answer that question, I'm going to ask you a little bit more. I'm not exactly sure what you're asking, but in the specific case that I've used as an example in this clip or when I explained it, I anchored it on the canine and the molar, but it can be on any of the teeth. It depends on how many teeth you want to over-erupt. In that case, the canine and the 7 was at the right height. I think the 7 had to erupt like 0.2, like 2 aligners only, very little. The 6 had to go quite a distance, so the 4, 5, and the 6 was the teeth that had to over-erupt or extrude the most. So I used the 6, which was the lowest tooth, for an anchor, and the canine, and the 7 and the 4 and 5 needed to erupt. So yeah, that's why I used them, and then I switched over, used the premolars, which erupted beautifully, and then I allowed the 7 erupted along with the 4 and the 5, and then I allowed the 6 to come into place. And the 6 is a big tooth, it's a difficult tooth, and a lot of the occlusal forces is on it, so I didn't want to risk that and have it over-erupt along with lots of the other teeth. So I used that as the only one to start erupting once all the other was in place.
So anchoring the aligner on the canine and molar, would you say that was only specific to the case that you did? Or is that general advice?
I would say that's general, because your curve of SPE, when you want to level it out, is from the canine to the 7. So mostly you want to erupt the 6, 5, and 4. That would be most of the times, yes.
Next question. Why do you think passive eruption works faster than active extrusion with attachments?
That's a good question. I think the passive eruption worked very well because I created the microspaces, and it's such a common principle. Teeth move till they touch. That's why we have over eruption when the bottom 6 are lost and the top 6 just over erupt. That's what happens. So I don't even need to predict it. It is going to happen. Then if I have to really break it down and go into the biomechanics of it, I would say it's the direction of the force and the inaccuracy of the attachments that made it less predictable.
What do you look for at aligner checks to confirm eruption is happening as planned?
Yeah, as I said previously, it's difficult because your movements are so tiny per aligner. What I just do general with any follow-up visit, irrespective of whether I check for extrusion, for any movement, I take the aligner out of the patient's mouth, I dry it, I dry the teeth, and I put the aligner back onto dry teeth, that there's no saliva covering the area between the tooth and the surface. And then it's so much easier to see if there's a void or not. Now, extrusion is easy because the aligner is lying there and the tooth is there, and you know it's actually supposed to touch there. Intrusion, the tooth is pushing on it, so it's not that easy to see where the intrusion happens. But you have to see in which direction the force is going to, the tooth have to move, and you check for a void. If there's a void, the patient can't move on to the next aligner. The tooth still have to move till it touches the aligner.